Please.
Good afternoon to everybody. I, first of all, would really like to thank you, all the organizer, for this really appreciated invitation and to share with you this very intriguing and compelling topic about the effect of genetic variant on controlled ovarian stimulation. I really enjoy all the lecture that we have before, and now we are going to face this other very important, I think, matter, because sometimes we think that the genetic could not influence our routinary activity. So here we are going to illustrate what we know, so what is the state of art about this kind of issue. These are just my disclosure. And let's go straight to the concept of the pharmacogenomics. What is the pharmacogenomics? The pharmacogenomics is the study that's related, that's associated what is the routinary clinical practice, so the prescription of the medication that we usually do to take care of patients, and the response to our specific genetic characteristics. And there are some specific variants, because when we speak about genetics, we think about something it is really rare. But there are specific variants that are called polymorphism that are quite spread in the population. So it's something, if you think about the shape of the face or the color of eyes, so it's something that is really frequent and could significantly affect the response to medication in general. This slide is taken from an old study that was published in New England, and it explains how the genetic variants could affect the ovarian response. They could affect the ovarian response at least at two levels. It could affect the kinetic of the drug that we prescribe, so the metabolism of the drugs that we prescribe to take care of patients, or could also affect the efficacy, so the interaction between the ligand and the receptor. And especially this one, okay, is the one that we most frequently observed in controlled ovarian stimulation, so the interaction with the receptor. So the pharmacogenomic approach is now becoming more and more a field of interest, especially in oncologic therapy. It was demonstrated how specific oncological therapy depends on the kind of prescription that we use and the kind of medication that we use. And our final goal, our dream, is to find the right drug for the right patient at the right dose. So it means that we should use the information that we have in our genes in order to tailor better our therapy for the patients. Describing in detail what we know about the ovarian response, because you know that the ovarian response is crucial for our fertility treatment, because if you have seen our previous presentation, it is quite clear that the number of oocytes that are strictly related to ovarian stimulation are strictly related to the live birth rate that we obtain. And it is real, it is confirmed in a fresh cycle and in a frozen cycle. So the ovarian stimulation is crucial for the IVF success. And we know that in the ovarian stimulation during follicular genesis, the main actors are gonadotropin and the receptor. So no surprise that the most widely determined genetic variants in ovarian response involve gonadotropin and the receptors. Let's start with polymorphisms that involve the FSH system. With FSH systems, we mean the gonadotropin itself and its receptor. And we know that the response to FSH, that is the exogenous medication that we described, is very important to recruit at least an adequate number of oocytes at the end of the stimulation. Here are the worldwide distribution of the most common investigated FSH receptor polymorphism. In the right corner, in the left and the right corner, there are two polymorphisms. These are RS6166. The RS is a code number for each kind of polymorphism that are in strong linkage disequilibrium, with an exception of African population, in which there is a different distribution. The one in the middle involves the promoter of the FSH receptor. As you could see, the distribution of the polymorphic variant is very very widespread in all the population. So we are not talking about something that is rare, but we are talking something that is quite frequent worldwide. Recently, in 2018, we have realized a systematic review and a meta-analysis of literature with the aim to sum up all the evidence that we have concerning the association between polymorphism and the ovarian response, investigated the number of oocyte retrieved, the FSH consumption, the number of mature oocytes, so the most interesting outcomes that we are usually measured during controlled ovarian stimulation. And what we know is that follicular, in this case, follicular receptor polymorphism, so the polymorphism that affect the FSH receptor, the one that is a single nucleotide substitution in which the asparagine is substituted by a serine that represents the polymorphic trait, is greatly associated with ovarian response. Probably is the most investigated polymorphism investigated so far. Indeed, in this slide, it is clear showed that the kinetic of the second messengers is different between those who carry the wild type form and those patients who carry the polymorphic trait. And this kind of molecular aspect greatly also influences the phenotype of the patient. Indeed, the menstrual cycle is different comparing these two patients, so the one that carry the wild type form and the one that carry the polymorphic trait, and also the serum levels are different. Indeed, the serum levels, the basal serum levels of women who carry serine, so the polymorphic trait, are significantly higher compared with those who are in the wild type form. It means that there is a sort of resistance to FSH even for endogenous FSH and not only for exogenous FSH. With our meta-analysis, we indeed identified that this kind of polymorphism could affect our response to medication. Indeed, those who carries the wild-type carriers showed greater number of oocytes than the polymorphic trait. And we know that the number of oocytes is very important to achieve at least a good, at the end of the story, a good percentage of live birth at the end of both fresh and frozen cycles. And another interesting thing is that those who carry the wild-type form require less medication than those who carry the polymorphic trait. So when we have the polymorphic trait, we need more medication, we need more drug, so the consumption of drug is higher, and the number of oocytes that we collect at the end of the stimulation is lower compared with wild-type form. So one intuitive approach is, can we increase the FSH dosage in those who carry this kind of polymorphism in order to compensate the effect of this genetic variant? The answer is probably yes, because we know that when we prescribe 300 units per day, that we know that is the maximum dosage that we usually suggest even for poor responder patients. There is no sense to prescribe more than 300 units per day, as we already know from the HRA guidelines. So when we prescribe the maximum amount of medication, there is no difference between the different haplotypes concerning this kind of FSH receptor polymorphism. So if we use the same maximum dose, there is no effect that we can appreciate on ovarian stimulation. Another indirect effect is observed in this study, in which the authors administrate higher amount of FSH in those who carry serine polymorphism, so in those who carry the polymorphic trait, compared with wild type 4 that codify for asparagine. As you can see in this graph, if we prescribe the same amount of medication, so 150 units, there is a discrepancy in terms of serum estradiol levels. And we know that the serum estradiol levels reflect the follicular growth, because it corresponds to the follicular growth. But when we prescribed more amount of medication in serine carriers, it seems that the difference in terms of estradiol levels are equal between groups. So this study is some kind suggests that we can increase our amount of medication for this kind of variant. Another very recent study confirmed that this was a multi-center study that was published by Polizos just a few months ago, also confirmed that the genetic model analysis reveals that there is a statistical significant difference in terms of hyperresponse in those who carry both the FSH receptor polymorphism that I speak to you before, so the one that is the code RS6166, and the one that involves the FSH promoter. What does it mean, hyperresponse? The hyperresponse means that we collect less than expected oocytes at the end of the stimulation. So a patient with hyperresponse is a patient with apparently normal ovarian reserves in terms of intrafollicle count or antimullerian volume. But at the end of the story, we retrieve less than expected oocytes at the end of the stimulation. Now, let's start to talk about the polymorphism that involved the LH system that are also important too, because you know that the LH is not only important for the ovulation process, but it is also important during folliculogenesis, because it is widely demonstrated that in granulosa cells and not only in thecal cells, the LH receptors are present, and that the LH is crucial for the final follicular growth maturation. So we should also think about polymorphism that involve the LH system, so both the LH receptor and the LH beta subunit. So let's start with the polymorphism that involved the LH beta subunit that was discovered in 19th, and it is quite frequent, especially in Northern Europe country and in Australia country. And this kind of polymorphism was related to increased consumption of FSH. So this study demonstrated that LH is important not only for the final maturation, but it confirmed that it's important for recruitment of our oocytes. Indeed, women who carried this polymorphism show an increased cumulative dosage during controlled ovarian stimulation comparing to those who carry the wild-type form. Consider that it is very rarest to find homozygosis form of this polymorphism, so in which we have both alleles that are affected by the polymorphism, but it is quite common to find the heterozygosis form, which represents the 10% of the overall population worldwide. This more interesting study also demonstrates that this kind of polymorphism is also associated with the reduced clinical pregnancy rate compared to those who carry the wild-type form. So maybe concerning the LH system, there is not only an effect on the cumulative dosage, but there is also an effect on the clinical pregnancy rate. Another interesting polymorphism involves not only the LH beta subunit, but also the LH receptor. This one is similar as the previous one that I told to you. It is a single nucleotide substitution that leads to a specific amino acid change from the asparagine that represent the wild-type form to serine that represent the polymorphic trait. What we know is that even this kind of polymorphism is quite frequent worldwide. If you think that the allele G represents the polymorphic trait, you see that it's very frequent in African population and Europe population. So it's something that it's quite common to find. And what we know from literature is that even this polymorphism, so those who carry the serine form, so the polymorphic trait, have an increase in cumulative consumption during controlled ovarian stimulation. So even in this case, there is a difference in terms of consumption of medication. More interesting, that it was recently demonstrated that women who carry this kind of polymorphism and was supplemented with the recombinant LH, so with the supplementation with LH, so an increase in clinical pregnancy rate compared with the other haplotypes. So this is the first study that demonstrated that the LH supplementation in those who carried the polymorphism that involved the specific region of the LH receptor could be of use. So another consideration that we should think is about this figure that illustrated what we know about this kind of polymorphism. According to these figures, it seems that those who carry the serine form, that is in the left corner, despite the levels of LH is quite good in the circulation. So if you see the picture, the levels of LH is comparable between whole groups. But when we have the polymorphism, the amount of LH that is inside the TICA cells, that we know that TICA cells is a target of LH action, is reduced when we have both polymorphism expressed. So another consideration that we can do, can we think about supplement with LH if we have this kind of polymorphism? We have enough evidence to say that. Unfortunately, there is only one study that was published really recently in 2021. And in this study, it was demonstrated that if we prescribe recombinant LH in the subsequent cycles, that was failed obviously before, and was tailored based on the LH haplotype, so based on the expression of the genetic polymorphism, there is a significantly higher clinical pregnancy rate compared with those that supplemented LH from day 6. So in this study, say that maybe we could try to prescribe more LH in the subsequent cycle, but it is important also to prescribe it from day number 1 instead of day number 6. This is the only evidence that we have so far. Another interesting variant that I would like to mention here is another one that involved the region 2009-1 and is another kind of polymorphism that was associated with the polycystic ovarian syndrome and could influence the ovarian response. Compared with the previous one that was quite frequent worldwide, this kind of polymorphism is conversely quite rare because only the 50%, the G allele is the polymorphic trait, it is only represented in 50%, in the 5% of population. So it is a quite rare condition. But what is interesting is that this kind of polymorphism works in opposite manner compared with the previous one. In this case, the system seems to work, more efficiently or even with more recruitment whole sites. Indeed, those who carry the polymorphic trait, even in heterozygosis, show increasing number of whole sites and increasing number of mature whole sites compared with the previous one. So it means that the polymorphism could help us not only to contribute or to recruit more host sites to women who are affected by poor ovarian response or hyperresponse, but could also prevent us to have a more chance to have ovarian hyperstimulation syndrome. Could help us to tailor better the therapies to avoid the hyperstimulation, despite we know that there are plenty way to prevent the ovarian hyperstimulation syndrome, because we know that the freeze-all policy or GnRH agonists are very efficient. So nowadays it becomes quite rare to find a patient with ovarian hyperstimulation syndrome, but we know that we cannot completely erase this kind of syndrome because there are still some cases as it was illustrated before. So just to summarize what I explained to you in this short presentation, is that first of all, we have a condition in which there is a need of more medication, and genes can explain us which are the target population. So when we have a specific polymorphism of FSH of LH system, it is a sort of relative deficiency of both gonadotropin. What does it mean, relative deficiency? It means that we cannot measure the deficiency through the the blood levels of this gonadotropin. So if we compare the blood levels of gonadotropin, the blood levels are at normal range. But despite this, the function of the gonadotropin in these circumstances are reduced. So in this case, the genes can help us to identify the patient that could need more FSH or could need LH supplementation. Especially for the LH supplementation, we know that luckily the majority of patients does not need LH during controlled ovarian stimulation because we use only FSH-based medication in the majority of cases. But there are some specific subgroups that are affected by a sort of LH deficiency, like this one, so the one that carry this kind of polymorphism that could need LH supplementation during ovarian stimulation. I think that maybe the only main issue regarding the effect of genetic variants on ovarian stimulation is the fact that the majority of the evidence that we have so far is based on retrospective study. Unfortunately, there is no randomized controlled trial that was conducted so far. So I think maybe it is the time to take the plunge. It is the time to move forward, because if we want to demonstrate that we can have an improvement in IVF treatment, we need to do robust randomized controlled trials. But I think also that the use of real-world information could be really of use, because now we should think that the genetic analysis is not so expensive as before. It's become cheaper and cheaper. So if we are able to collect a huge amount of data, because the real power of the real world data is the number of observations, and we know that the larger is the number of observations, the most accurate is our data analysis. So I think that both of them, so a large registry that could collect the genetic profile of the patients, as well as well-randomized controlled trials, can help us to clarify in the future if the genetic profile of the patient could be of use. Anyway, what we know so far is that specific polymorphisms are associated with increased FSH resistance to exogenous gonadotropin, or in a sort of impairment or LH system. This is the reason why, together with the Poseidon group, we propose or we consider in women who are characterized by hyperresponse. Like I explained to you, we should think of hyperresponse not just the number of oocyte retrieved. The hyperresponse means that we retrieve less than expected oocyte compared with the intrafollicle count that we have at the beginning of the stimulation. So I think this time to move forward, okay, and try to investigate this kind of polymorphism even in our routinary activity, even if the evidence so far are not so robust as for the other treatment. Finally, let me thank you, all the staff, and I'm really honored to be here to represent my university, and I really thank you for your attention. Really, thank you.
Grazie, Professor Conforti.
Thank you.
A very exciting area for the future. You mentioned the cost is coming down. While the audience prepares questions, I would like to see one or two. Can I ask how much does it cost to do a receptor polymorphism, for example?
If you think about, for instance, the anti-Mullerian hormone, because now we know that the anti-Mullerian hormone becomes very common measurement worldwide because it is one of the most recognized ovarian marker. The costs are quite similar because even for the anti-Mullerian hormones, the costs are quite high. So the main issue is that we need more data because the number of variables when we investigate the genome is quite huge, because now we know the association where we consider just one polymorphism, but we consider most polymorphisms together, the things become more and more complicated. But if you think about the cost, it is not more than do an appropriate anti-Mullerian hormone test or a good intrafollicle count. Maybe the intrafollicle count is cheaper, of course.
Thank you. Questions from the audience? on polymorphism, please?
I guess is this on?
Yes.
I guess if you wanted to play sort of, I mean, first of all, excellent presentation, but I guess if you wanted to play sort of devil's advocate with regards to the usefulness of the research and the testing of these variants, you could say there are some people who need a bit more LH, but the people who don't need it don't necessarily have a detrimental effect from it. So if you give everybody a pretty high dose of FSH and LH, is it really necessary to know the variants?
Okay, thank you for your questions. I think that the genes or the genotype analysis could help us in this sense. Regarding the LH supplementation, it is quite clear that we don't need LH in every kind of patient that we treat them, because luckily the LH system works properly, especially for normal responders. But despite this, for instance, there are women who are at advanced age that need more LH because it is a source of deficiency of the LH system, as well as women that are characterized by specific polymorphism. In terms of dosage, I mean that the 2-to-1 ratio, FSH, LH, is the most efficient way to prescribe both medication. And regarding the effect of the FSH polymorphism, I think that it is important also to not exaggerate it with the dosage, because we know that it is useless to prescribe plenty of medication in order to collect the number of oocytes. And in this sense, the polymorphism could help us to tailor better our therapy. Obviously, we need more and more evidence. Compared with the previous presentation that was presented so far, you see that I presented to you, in the most of cases, a retrospective study. This is the real limitation so far. But I hope in the future, because I think that in genes there is the answer in many things that we cannot help, we cannot improve our treatment. Think about women with unexplained infertility, or those with recurrent miscarriage or recurrent implantation failure. There are many things in which I think that the genes information are important, because there is a box, it is an unexplored box. So maybe in the future, hopefully, considering that the cost is even more cheaper than we usually think, okay, I think that now we should move forward and to develop good quality studies, as well as a good number of observations with real world data.
Thank you so much, Professor Conforti. I think in the interest of time, we might move on, because we will have a panel discussion. So the audience has a new opportunity to ask questions or even bring some clinical scenarios related to our presentations. I think that will be a valuable session. Thank you so much again.
Thank you.